and welcome. It is my pleasure to welcome you to our Alzheimer's Society of Saskatchewan Evening of Education. Tonight's presentation will be on understanding dementia progression, what to expect and how to prepare, presented by Dr. Krista Lagimodiere. My name is Heather Dash, and I'm the Program Manager for Programs and Services team for the Alzheimer's Society of Saskatchewan. As we gather here today, I acknowledge that I'm joining from Regina, which is Treaty 4 territory and the homeland of the Métis. The people of Alzheimer's Society of Saskatchewan are privileged to live, work across the traditional sacred land as we know as Saskatchewan. We recognize the legacy and enduring presence of the Cree, Dakota, Dene, Nakota, Lakota, Sioux, and Métis people, who are the original stewards of the rolling hills, rushing rivers, and living skies we all share today. As an organization, we acknowledge the harms of the past and how Indigenous people are still impacted by the process of colonialism. Through education, partnership, and collective action, we're committed to honoring our relationship with the land, our treaties, and each other as we journey towards reconciliation. Before we begin, I would like to take care of a few housekeeping items. First off, I would like to thank our supporting sponsors, SaskTel, Telcare, and SGI. The presentation tonight will be recorded. Please note that only the presenters are being shown on the screen. As participants, your faces and names will not be shown, and you'll all be muted. If any attendees would like closed captionings, we have enabled automatic captions, which you can select at the bottom of your screen. Following tonight, an email will be sent out to you with a short evaluation survey, as well as links to all the resources that may be referenced in the presentation. During the presentation, you can type your questions for the presenter in the Q&A function near the bottom of your screen, not the chat box. We'll have a brief question period at the end of the presentation where I will read questions that have been typed in to the presenter. We ask that you keep your questions relevant to the topic being presented tonight and general questions only, not personal. The presenter will not be giving personal advice and will not comment on personal situations. I would like to introduce our guest presenter for this evening. Dr. Krista Lagimodiere is a geriatrician in the Saskatchewan Health Authority in Saskatoon, where she practiced since 2020. A graduate of the University of Saskatchewan College of Medicine in 2015, she completed her internal medicine residency in 2018 and a fellowship in geriatric medicine in Vancouver in 2020. Dr. Lagimodiere is an assistant professor in the Department of Medicine at the U of S and actively contributes to teaching and leadership roles. Her clinical focus includes team-based care for complex, frail older adults in both hospital and outpatient settings. She's sought-after speaker on dementia, age-related topics, and serves on the membership committee of the Canadian Geriatric Society. Since joining the Alzheimer's Society of Saskatchewan board, in June of 2022, Dr. Lagimodiere has continued to champion evidence-informed, compassionate care for individuals impacted by dementia. Dr. Lagimodiere, you can now, I'm going to stop sharing my screen so you can start your presentation.
Okay, can everyone see my slides? Okay.
Yes, it looks good.
Good, perfect. Thanks, Heather. I was a little nervous at the beginning there because for whatever reason I couldn't hear you speaking, but thank you for that wonderful introduction. Everything is working out great now, so all is well. So I want to thank you for inviting me to present today on dementia progression. When I was invited to do this talk, I thought, wow, what a great topic, but I also thought, wow, what a complex one. And I think what I'll just open with is that if you have a loved one who is progressing with dementia, or if you have questions about dementia progression, please know that it is complex. It is not something that we can predict 100%. Every individual journey is very different, but I will do my best to give you a roadmap per se, so that as you navigate this disease, you have a sense of how you might prepare as each step unfolds. So for today, we're going to cover the different stages of dementia and what to expect at each stage. We will improve care partner preparedness through increased knowledge of resources and services when navigating transitions in the disease journey. And we will review and understand when observed changes in a person living with dementia may warrant consultation with a healthcare professional. So what is dementia? Dementia is an umbrella term to describe a set of symptoms that are caused by disorders affecting the brain. And typically we think about dementia as a hybrid condition whereby there are cognitive symptoms that impact function. And these changes are a change from a prior baseline. So any cognitive symptoms that arise in an individual that were not present before, and any functional impairments that arise whereby someone loses the ability to perform daily activities that they previously could do. I want to highlight that when we talk about dementia, there's often this misconception that dementia is synonymous with Alzheimer's disease, which is partially true, but somewhat incorrect, in that dementia is just an umbrella term, as I discussed, and Alzheimer's disease is the most common type of dementia. So that's often where the confusion lies, but there are many types of dementia. Other subtypes I've listed below here. There is a long list, but a few that I'll highlight are vascular, frontotemporal, Lewy body, and Parkinson disease related dementia. So we have a heterogeneous group of conditions that fall under the umbrella of dementia. We also know that dementia is not a normal part of aging. So aging alone does not guarantee that you will develop dementia. It's estimated that upwards of 40% of people over the age of 65 will have some age-related memory changes. And some of those changes with time are actually better than our younger counterparts. So it's not always negative changes that happen with aging. For example, our knowledge about sort of wisdom, that there's science behind that with age we develop more wisdom and knowledge in that way. But dementia doesn't always affect older people either. There are early onset dementias that can occur in those under the age of 65. And we also know that dementia is not always memory loss. Memory loss is the cardinal symptom that we see in Alzheimer's disease, but memory changes are not the only symptom that we can see in dementia. And in fact, there are some causes of dementia that don't actually affect memory, such as frontotemporal dementia. So it's very much dependent on the underlying cause of dementia. For the purpose of this talk, I am going to focus on Alzheimer's disease, however, because it is the most common, and because when we talk about progression of dementia, we often use Alzheimer's disease as our sort of blueprint to understand dementia progression. And so Alzheimer's disease is a disease of the brain. It's the most common type of dementia. It most commonly occurs over the age of 65, and we estimate that about 2/3 of dementia cases in persons over the age of 65 are due to Alzheimer's disease, The condition is a complex one, but the simple way to describe it is that there are abnormal proteins that accumulate in the brain, and those start to lead to a number of sort of fires in the brain that lead to cellular death, and that can result in cognitive symptoms. And often those changes in the brain occur sometimes decades before symptoms arise. It's gradually progressive, and at this present time, there is no cure. My hope is in my lifetime or during my time as a geriatrician, I will live to see a cure for this condition. So before we move along to the stages, I want to just share that every dementia journey is unique. So please carry that with you as we discuss each stage today. Progression is gradual. On average, we estimate that most cases of typical dementia due to Alzheimer's disease will last about a decade. This is variable, but we generally look at studies that support this. Staging is helpful, and I'll break down each stage as we move forward through the talk. Each stage is dynamic, so symptoms can ebb and flow Things can change as the disease progresses. A symptom that occurs in the mild stage may dissipate by the time someone reaches the moderate to severe stage. And so staging is important because it allows us to prepare for potential symptoms. And it's also important that we reassess people at each stage because the condition is so dynamic. In clinical practice and in research, we use this global deterioration scale. And I don't expect people to retain this. It's a very busy slide, but it just illustrates the complexity of staging. This was developed by a researcher in the 80s, and he looked at staging of dementia in 7 stages. And as you see here, stage 1, 2, and 3 basically describes cognitive changes that occur with age that are not dementia. So there's the staged fashion of stage 1 is that there's no cognitive changes. Stage 2 is very mild. That's usually what we would refer to as, quote, age-related changes. Stage 3 is when we start to see a transition where there's changes more than we'd expect for aging, but we're not quite at a stage where we would say that someone meets criteria for dementia. So the changes are still pretty mild. At stage 4, that's where we transition to what we would typically describe as mild dementia. 5 and 6 is sort of your moderate to severe stages, and then 7 is very severe to end stage dementia. So this just kind of gives you a summary of these stages, and I'm going to break them down in bite-sized pieces in a way that hopefully makes a bit more sense. So there's 4 primary stages we think about when we look at staging dementia. There's early stages or mild, middle or moderate, late, severe, and then end of life or end stage dementia. And it's important to remember that with many forms of dementia, particularly the neurodegenerative forms like Alzheimer's disease, it is a progressive terminal condition, meaning we don't have a cure for it. And we expect that if individuals live long enough, they will eventually reach those end stages if they don't develop other health issues that might cause death before that. So the first stage, early mild stage dementia, typically we see mild cognitive changes. So memory decline, difficulties with communication, trouble learning new information, so retaining new information. In practice, this might be situations where individuals are becoming more repetitive in conversation. You may need to repeat things more often. They may need to write down reminders more. If they go see their physician, they may not recall all those details as readily, and this might become a more frequent problem. A thing to also keep in mind is the changes are usually noticeable by close family and by healthcare professionals. So there are evident changes happening. Other common things we can see in mild stages are mood and personality or behavioral changes. So withdrawal from social situations is quite common. And some of this is due to the fact that individuals have some insight into the communication difficulties they may be having. So they naturally withdraw from social situations, whether it's self-esteem or a feeling of shame. And so it can be very difficult in this stage for individuals when there's insight. It's also quite common to experience late life symptoms of depression or anxiety. And when I have an individual who's over the age of 65 who has never been depressed or anxious in their life, and they start to develop these symptoms later in life, I automatically worry about the possibility of early dementia developing. And so these symptoms are very common. Functional changes are the other side of the coin that is needed to diagnose dementia. And so in mild stage dementia, we see mild functional changes. And typically these changes occur with more complex, what we call higher order tasks. So these are things like driving, cooking, following complex recipes, managing our finances, bill payments, filing our income tax, managing complex medication regimens. All these things we refer to as more complex tasks. And so in early or mild stage dementia, one or more of these tasks start to become more difficult. And this is when we often need to have support from loved ones. Typically, though, these changes allow us to still live independently. So many people with early stage dementia are still living in their homes, they're still fairly independent, but they might need some increased supports around the house, whether that be, an automatic medication dispenser, perhaps installing a stove shutoff device to prevent the stove from being left on. And some people do decide at this stage to move to an assisted living facility in preparation for more functional needs that may occur. I've left a little note at the bottom just to remind us all that early or mild stage dementia is not the same as early onset dementia or young onset dementia. So oftentimes the terms can be confused, but when we refer to early stage dementia, we essentially are describing mild dementia. Early onset dementia refers to dementia developing in individuals under the age of 65 and usually under the age of 60. And so this is a whole different category that we won't touch on today, but just to keep in mind there's a distinction there. So what are the next steps if you have a loved one or if you yourself are experiencing mild stages of dementia? Well, the first step is if you're noticing changes that are worrisome, you should book an appointment with your family doctor. And at that appointment, typically what will happen is, you'll likely get some baseline cognitive testing done. There should be a review of your functional abilities, a comprehensive medical exam, usually some standard blood work to rule out other causes of memory changes. And sometimes it's also an opportunity to order a CT brain to look for any strokes or any other abnormalities that might explain the changes. If you have an established diagnosis of dementia, specifically Alzheimer's disease, you may be a candidate for one of the memory pills that are available. And we call these cholinesterase inhibitors. Donepezil or Aricept is a common one we prescribe. So that might be an option for you in this stage. And typically it's the mild stages that tend to respond best to these medications. Driving. So this is often a challenge in that it's a sense of autonomy and independence, and it can be very difficult to transition into retirement from driving. But often early stage dementia is when we start to see challenges with driving. And this may mean a report is submitted to SGI. In Saskatchewan, we have a legal mandate to submit a medical report to SGI if anyone has a condition which a healthcare professional feels may lead to safety concerns on the road. And so oftentimes this does happen at this stage, but there are individuals with mild dementia who still safely drive. So it's very dependent on the individual. One thing that I will state throughout the talk is completing legal documents. So this is so important. When I talk about legal documents, I'm talking about all the legal documents that are needed for advanced care planning. And in clinic, I often talk about the trifecta being power of attorney, living will, and advanced healthcare directive. These are so important, and I encourage everybody to speak with their lawyer, have these established, assign a trusted family member or friend who can act as your substitute decision maker in order to prepare for changes with the condition whereby you may not be able to make decisions for yourself. So I always highlight this as an extremely important thing that should get done early and proactively. When I talk about dementia progression, I like to talk about sort of a sailboat analogy. So in mild dementia, you can think about the individual on a sailboat. And typically in mild dementia, the individual is still able to manage the sails, steer the boat fairly independently, but you typically need some family on standby, some crew on standby to be around in case there's an emergency. Moving on to middle or moderate stage dementia. So moderate stage dementia is, essentially, progression from mild. And so we see more pronounced cognitive changes. And some changes that we may see are, whereas in mild, individuals typically remember personal details about their life. In moderate, they may start to forget personal details such as phone numbers, addresses, or even names of acquaintances. Typically, individuals will still remember names of close family, but they may start to, not remember names of nieces or nephews or people they may not see as regularly. They also have more evident difficulty remembering recent events and conversations. So the repetitiveness, the forgetfulness becomes more evident, and they may often have trouble staying oriented to date, time, place. They may have more difficulty making and executing complex decisions. Difficulty with language and expressing self. So this is where we may have trouble with finding the right words or even expressing ourselves in conversation. And insight and awareness of one's condition tends to decrease in this stage, which makes it really challenging for caregivers, especially because when you notice that your loved one may need more help, this is often when we see resistance to care because there's this lack of appreciation at times or insight into one's condition. In addition to the cognitive changes, there are mood, personality, behavioral changes that start to arise more prominently in this moderate stage. And I've listed a few here. There are many, but these are some of the symptoms we see as dementia progresses. And we treat all these symptoms differently, but certainly it's the behavioral symptoms in dementia that often lead to significant caregiver stress, burnout, and sometimes the need for hospitalization. So they are very important symptoms to address. In addition to the cognitive and personality behavioral changes, we see further functional changes. And so typically, whereas in mild stage, we see people with sort of changes with those complex tasks like cooking and driving. In the moderate stage, individuals start to become more dependent for what we call daily personal care or more of the basic functions. So if you think about what you need to do every morning to get ready and go to work or get ready to start your day, brush your teeth, groom yourself, have a bath or shower, get dressed, prepare some breakfast, eat breakfast. These are the things that we define as basic activities of daily living. And in the moderate stage, this is typically when one or more of these start to become impacted. Examples may be, inability to remember to shower. And so now they need home care to assist them with that. Caregiver involvement increases. There may be the need for increased level of care, such as home care supports, or sometimes even moving to an environment that provides 24/7 supervision, such as a personal care home. This is often when we start to talk about tech supports like GPS trackers, if someone is wandering, or falls detection devices if someone's mobility is declining. And often at this stage, typically we say that driving should not occur. And most people in moderate stage dementia should not drive. And we say this because there's evidence to support that if you're unable to do one of the basic tasks of your day-to-day life, like bathing, showering, dressing, you do not have the functions to do more complex tasks like driving. One thing I will highlight here is typically in the moderate stage, I mentioned that this is often when we have challenges with care, and this can often lead to risk of caregiver stress and burnout. So this is where we often talk about caregivers putting on your life vest first. And that's where, I ask you to seek help proactively. Talk to family and friends and healthcare professionals. Seek the Alzheimer's Society of Saskatchewan for resources. Plan for those additional supports, whether it's community or private home care, respite care, which allows for sort of transitional beds if you need to leave for a few days or a weekend. And then adult day programs, which there are many in the city of Saskatoon and perhaps others in rural areas that I'll have my colleagues here on the talk speak to. But generally speaking, finding activities in the day to cognitively simulate and allow your loved one to socialize, to allow you time to regroup as well. Joining caregiver support groups, connecting with social work, attending counseling, and allowing yourself to grieve gradual losses. So we often talk about grief in the sense of a loved one who dies, but we often overlook grief that happens with loss of a loved one's function, cognition, abilities. And this is something that individuals with dementia or caregivers of those with dementia experience quite readily throughout the disease journey. I'm highlighting a few examples of when you would seek professional health or sometimes even seek emergency help if there's any acute change or worsening behavior in a short time frame. So if there's a very abrupt change in an individual's function or cognition over hours to days, this may indicate an underlying medical condition or an illness such as delirium, which is something we deal with a lot in the hospital, where someone has essentially an acute emergency where they have what we in layman's terms say acute brain failure, where there's an acute medical problem that results in a chemical imbalance in the brain that can be quite dangerous. And this can be due to a stroke, a heart attack, an infection, a medication side effect, a number of things. So if there's any abrupt change in someone's cognition function that's very dramatic and occurs over short hours to days, please seek out medical attention. Another reason would be if behaviors are dangerous, distressing to the individual. An example might be, frightening hallucinations that are persistent, or if an individual is becoming more resistant to care or paranoid, or if there's any responsive behaviors being physical or verbal behaviors that may be a risk of harm to others. That would be a reason to seek help. If there's any falls, injuries, environmental safety concerns like risky driving or wandering, exit-seeking behaviors. When I talk about exit-seeking behaviors, I'm talking about, the individual who's living at home, but they wake up at 3 a.m. because they think it's morning in the middle of winter. They put their clothes on and they leave the house. So those would be things we worry about. And then, of course, any caregiver stress, mood changes. If you're not coping as a caregiver, that would be another reason to seek help for you as an individual. So in moderate stage, I often think of it as somewhat of a turbulent time, because it's this transition point from things were going okay to now all hands on deck. Caregivers are now taking the reins. The individual with dementia is less able to direct their care. And this is often a really challenging time. And it's highly variable how long moderate stage lasts, but it often is, can be several years. And so it can be a lot of uncertainty, but that's where, we really look to supports to help us navigate that. Moving along to the severe stage of dementia. So late or severe stage, again, we continue to progress where now our cognitive symptoms are severely impaired. So typically this means that individuals may not remember the name of their spouse, their children. They may even forget their own birthday. So personal details become foggy. Typically, long-term memories are generally intact until very late in the disease, but even long-term memories can start to become affected in this stage. And so they may forget details about their life. They may also have difficulty recognizing familiar faces. And communication difficulties continue to decline, where speech, language, ability to formulate sentences can become quite impaired. Functionally, most people in this stage now require, full assistance for all of those personal daily care activities. And often they become incontinent, whereby they need to either wear continence products or they need cueing to use the toilet because the brain functions don't communicate with the bladder anymore to empty the bladder appropriately. And so there's changes that happen that way. Falls becomes a considerable risk because as the dementia progresses, our motor planning abilities decline. In other words, our ability to plan how we move, how we walk is impacted. And usually people in this stage do need 24/7 care. And that might be in Saskatchewan looking like, a private 24/7 live-in caregiver, which most people aren't able to afford because that's extremely expensive. So most individuals, I would say, would live in a personal care home type environment or long-term care. Now, late severe stage dementia has all the same symptoms we see in moderate, but what I will say is that these symptoms may change over time. So if there were prominent delusions in moderate stage dementia, they may slowly dissipate in severe stages and you may have new symptoms arise. So that's why it's so important to reassess at every stage and have frequent reviews of symptoms, because medications that may have been started to treat a symptom a few years ago may no longer be needed in the later stages of dementia. And that's where in my practice, we often do medication reviews to make sure that we're reducing pill burden, we're making sure that only essential medications are continued. And if there are medications that were started several years ago that may not be providing benefit anymore, it's an opportunity to get rid of them. I often talk about dementia as a team-based sport. So I could not do my job without a team. And it becomes increasingly important as the disease progresses to rely on our team. As dementia progresses, we start to have difficulties with feeding, nutrition, and oftentimes we involve our dietitian colleagues, our speech language pathology colleagues to help with feeding strategies in dementia. We work closely with occupational therapy, physiotherapy to allow for gentle exercises, preventing pressure injuries. We want to monitor, even though individuals may not be able to communicate verbally their needs, we are trained to look for signs of pain or other unmet needs that may present as agitation or verbal aggression. And so we look for underlying triggers of that, whether it's constipation or urinary retention or a medication or pain related to arthritis. So it's often looking at what those unmet needs are to treat an underlying symptom. And we often do a full medical review, medication review, as I mentioned. We want to review those advanced care goals because this is a time when things are changing, things are progressing. We want to make sure we prepare for the future. And oftentimes, as I mentioned, 24/7 care is almost exclusively needed at this stage. So I found this photo of a lighthouse in the distance. And so when we talk about severe dementia, it's still that all hands on deck, if we look at that sailboat analogy. But the hope is we start to see the shore, we start to see the light at the end of our journey in preparation for the advanced or end stages of the disease, where we want to have a peaceful transition. And so when we talk about the fourth stage or end of life stage, this is typically what we would describe as sort of an individual with a terminal condition. Typically, this is when we would involve palliative care. It is variable, but typically we say that when appetite is significantly affected and there's weight loss and an individual no longer accepts food or drink, we often say that the risk of dying within 3 months is quite high. Now, this is highly variable, but typically we say that individuals are usually in their final months of life. Often at this stage, people are nonverbal. They may very well be bedridden or confined to a chair. Their ability to walk, talk, eat becomes impacted. And as we approach end of life or death, we can see sleepiness, drowsiness, fluctuating attention. And this often is a sign that, the end of the disease is coming near. And so what we want to ensure in this stage is that we have active involvement of our, what we call substitute decision makers. Typically that might be a spouse, an eldest child, whoever is assigned on a legal advanced care directive. And they are often required to work alongside the team to prepare for what is to come with the end stages of the disease and to ensure that we're tailoring management in a way that honors the individual, allows for a dignified death. When we talk about palliative care, we talk about palliative approaches to care, which essentially just means an approach to care where we focus on symptom management, so treating an individual for symptoms rather than trying to cure a condition, because the condition we're dealing with is not curative. The focus is on symptoms and making sure someone is comfortable, at peace, and pain-free. And so we often are treating things like pain, anxiety, discomfort, agitation. This is often a time when we involve social work, counseling, grief bereavement support, all those wraparound supports to prepare for this stage. And, really the cardinal features of this care is, ensuring we keep the physical, emotional, and spiritual care at the forefront. And so essentially we want a very holistic, comprehensive approach to care in this condition. And the hope is we reach a point of peace, and we always want caregivers to feel at peace with how the disease ends for their loved one. So dementia is usually gradually progressive. Stages are mild, moderate, severe, and end stage. Management at each stage is dynamic, ever evolving, and individualized. It is not a one size fits all approach. And that's why a team-based approach to care is so very important. And I'm very grateful for the team that I get to work with in my clinic. We recommend seeking supports early and often. And those supports may include, but not limited to, your healthcare team, your family, your friends. The Alzheimer's Society is an invaluable resource. And I'll highlight once again, I think I've brought this up several times now, but I stress this because it's so important to plan for the future with any condition, but particularly for conditions that are progressive and incurable. So planning for the future by completing those legal advanced healthcare documents early so that when a crisis occurs or as the disease progresses and when an individual living with dementia is no longer able to make decisions for themselves, it is always easier if there is a document outlining their wishes, and it allows family caregivers the ability to feel a sense of guidance and confidence moving forward when they need to guide the care for their loved one. So thank you. I appreciate the ability to present this evening. Of course, I've left my contact info here, but I understand that I will be sharing the slides as well with the team here. And I thank you all for taking time this evening to share in the conversation. Thank you.
Thank you, Krista. What I'm going to do, Krista, can you stop sharing your screen? And we're going to give everybody time to answer, put some questions in the Q&A, and I'm going to share my screen. So to talk a little bit about the Alzheimer's Society. Okay, so while everybody's entering your questions, I will share a few slides on the Alzheimer's Society. So first off, the Alzheimer's Society of Saskatchewan is the province's leading dementia care and research charity. The vision of the Alzheimer's Society is to live in a world without Alzheimer's disease and other dementias. And the mission is to empower people to live well with dementia through the delivery of programs, services, advocacy, awareness, and research. We're accredited by Imagine Canada Standards Program for excellence in nonprofit accountability, transparency, and governance. The Standards Program is a Canada-wide set of shared standards for charities and nonprofit. Did you know that 3 out of every $4 that the Alzheimer's Society receives comes from donations? Donations come from events like tonight's Evening of Education, as sponsorships, gifts in wills, monthly donations, or a general donation to the Society. A couple things to note is a person does not need a formal diagnosis to be connected with us. We support those affected by Alzheimer's disease and other dementias and have resources and knowledge about many different types of dementia. What you can expect from the Alzheimer's Society of Saskatchewan. First, individual information and support. This is available for both people living with dementia and their care partner. Learning opportunities. This includes learning series. These are courses to help people living with dementia, their families and friends to live as well as possible with the disease. The course offered is built upon each other, covering the continuum of the disease. And evenings of education like tonight's event are standalone topics presented by content experts. Connections. This includes support groups. Alzheimer's Society has Excuse me, Alzheimer's Society has the support groups offer a chance to exchange information with others living with and affected by dementia, access the most current information, learn and share practical tips for coping with change, decrease feelings of loneliness and isolation, express feelings and be reassured that these feelings are normal, and find a sense of hope. Minds in Motion is a 2-hour program that is held weekly that combines physical activity and social activity for those with early stage dementia and a friend, family member, or care partner. Connection to other organizations. This includes providing information on available services provided by the Saskatchewan Health Authority or other government agencies, or a list of private or community-based organizations that help support people's dementia journey. Our shift to also offering virtual and online programming has increased our ability to provide additional programs to our communities. We have trained program and service staff that provide dementia information, support, and education throughout the province. Our provincial office is located in Regina with additional resource centers in Saskatoon and various locations across rural Saskatchewan. In 2024-2025 fiscal year, we served over 3,300 people from 360 Saskatchewan communities. If you have questions about dementia or need to talk to somebody, call the province-wide toll-free dementia helpline at 1-877-949-4141 or email helpline@alzheimers.sk.ca, Monday to Friday, 8:30 a.m. to 4:30 p.m. Take a look at our Alzheimer's Society of Saskatchewan website and connect with us through social media. On the website, you can scroll down to programs and events to see our upcoming event information. Okay, I'm going to stop sharing my screen and see what questions have popped up. Okay. So the first question is, so from the information, it seems that there will be fluctuation between stages. Did I understand that correctly?
Thanks. Good question. In certain ways, yeah. So there are evolution of symptoms as the stages go on. So by fluctuations, if you mean, that things will evolve over time, then yes. When I think about fluctuations, I think of sort of things get good, things might be good, and then things might not be so good. So yes, there's certainly going to be good days and bad days for individuals living with dementia, and that can vary from person to person. But as far as kind of the progression goes, symptoms may arise in the moderate stage, but that symptom may dissipate as the disease progresses into the severe stage. So does that make sense? I hope that answers your question.
Okay. If it doesn't, they can text in later. The next question, Krista, and I know you knew this question was coming. I've read about a new drug called, okay, I can't pronounce it. Last, can you pronounce it for me?
Lecanemab, yes.
Yes.
I
And
was
then,
preparing for this question. So the short answer is yes. Health Canada has just approved this drug. It's been approved by the FDA in the States for a couple years now. So Health Canada was somewhat dragging their feet. I shouldn't say that, but there were a lot of delays, and they just announced a couple weeks ago now that it has been approved. Now, the process in Canada, once a drug is approved by Health Canada, that does not mean that every individual now immediately has access to that drug. The next step is, because we have our healthcare system is managed provincially, so each provincial jurisdiction will work with the government to determine a funding model for the medication. And so I don't have any further information on when or next steps for when that will be. I've been told that typically once a drug is approved by Health Canada, it may take a couple years for it to actually become readily available for physicians to prescribe in the provinces. As far as private ability to pay for it, that's a question that I don't know how to answer yet, but I'm sure that we will learn more as each province starts to work away at strategies to fund the medication. What I'll say in brief about this medication is it is a novel drug. It's what we call a monoclonal antibody that binds to one of the sticky abnormal proteins that accumulates in the brains of persons with Alzheimer's disease. And that protein, which is bad, accumulates in the brains of people with Alzheimer's disease. And that is what leads to cell death, neurodegeneration, and all the symptoms of Alzheimer's disease. So the drug was studied in persons with early to mild stage Alzheimer's disease. Essentially the way it works is it binds to those sticky proteins and tries to clear them from the brain. And so that drug did show modest benefit in potentially slowing the progression of the disease. And so certainly it's an exciting new treatment because we have not had a new treatment for this condition in decades. But as far as when it will be readily available for use in Saskatchewan, I would say we're a ways away from that.
Okay, thank you. Okay, the next question I have is, have you heard anything about the study of plazogens as a possible reason for dementia developing? Is this being studied? Have you heard of anything? You can go into the question and answer thing to see exactly how it's spelt.
I have not heard of this. I will have to do my reading and homework after this, but I apologize. I can't comment on that question. I would imagine it's quite novel, experimental at this stage, but it's certainly not something that I've heard much about. Thanks for the
Okay.
question.
The next question is, how would you suggest a family or spouse manage when they're noticing symptoms, but the person with the symptoms is not or cannot see that are they are symptoms and refusing to admit to themselves or more importantly to their doctor?
That is very common and very challenging. So oftentimes, what you're describing is basically an individual has changes that others are noticing and they may not have insight into those changes. And obviously, if someone doesn't have insight into the changes that are happening, they're not going to seek help because nothing's wrong, right? So that's really challenging. I'm not sure if I have a uh, right answer for everybody, but I would say, generally speaking, continue to be a support for that person. Um, Continue to encourage or find ways to perhaps accompany them to an appointment, ensure that they're safe. So if there's concerns about driving, let's say, or medication management, perhaps find ways to check in more frequently and slowly allow them to come to the realization that, they may need help. If there are imminent concerns with an individual's safety, then, certainly, it might be a good idea to reach out to a trusted healthcare professional. Certainly, there's not a right answer for everybody, but continue to be a good support for the individual. And if there's imminent safety risks, there may be an opportunity to talk to their trusted healthcare professional about those concerns. But ultimately, usually you have to wait for an individual to accept an assessment, and that can be difficult.
Thank you for that answer and for that difficult question. I have another one that says, thank you so much for the incredible wealth of information. It's such a horrible condition, and your stress on preparing in advance also gives one control. And just ask, are you sharing the slides? And yes, the post-event email will have the slides included, as well as a list of a whole bunch of resources that was kind of touched upon tonight, but obviously, because of time, could not go into great depth. But the post-event will have both slides and links to other resources. Okay. Can you address recommendations on how to talk with somebody with dementia when they're having difficulty recalling a word or name and when they talk about somebody who has passed as though they're still alive? Should you redirect or assist?
Thank you for the question. So generally speaking, when there are memory gaps or misconceptions about reality, we often want to avoid arguing with an individual. So typically the strategies might be to reminisce about the past, redirect the conversation, change the subject, but not to argue, not to correct. Um, if if you're able to gently redirect or correct, depending on the person, that might be a way to go about that. But um, you know, in speaking with family and caregivers, often trying to correct or redirect, or sorry, trying to correct or um, sort of yeah, correct an individual can sometimes lead to frustration, and nobody really wins in those situations. So oftentimes it's about sort of choosing your battles per se and redirecting, reminiscing about the past, sort of living in their reality for a moment, and being a support during those challenging times.
Okay, this is another one. Have you heard of NeuroQ? It's like neuro and then a large Q.
Yeah, these are some tough questions tonight. I have not heard of NeuroQ. I'm adding it to my list of homework. Again, I imagine this is also a novel, experimental type thing that is in the world. So certainly I will look into that for future.
Okay. The next question is, what are the studies showing for success in the new drugs and how does it compare to the old drugs?
Yeah, that's a good question. So, to summarize, I would say that the new drugs are not a cure. Um, in other words, they don't stop the disease in its tracks and cure it from progressing, but they do slow progression. And so, one of the drugs, lecanemab, has been shown to sort of delay progression um, by about 5.5 months. So, in other words, if someone would lose their driver's license in April due to dementia, being on this medication may allow someone to drive for an additional 5 to 6 months. So that's typically the way we think about it in real life practice. So the benefits are still quite modest, but it certainly is, more than what we have now. The current medications we have, like Aricept and Episil, they help with day-to-day symptoms. So they may allow for sharper processing speed. They may help with some of the memory lapses. The benefits are typically seen in the mild to moderate stages, and the benefits start to become less helpful in the later stages of the disease. But the benefits are quite modest again. So these new drugs, certainly there's promise in that they seem to slow progression to a degree, but the benefits are still relatively modest. I guess it depends from person to person because some people may see great value in delaying progression by 5 to 6 months. So certainly it really is going to be individualized based on the person. And there are people that may decide that that's not of meaningful benefit to them. So I'm very interested to see how this new wave of therapy is going to affect treatment moving forward.
I have another question. Is there any
Mhm.
dietary concerns during the different stages?
Um, Dietary concerns. So I'm not sure if there's dietary concerns per se, but generally speaking, we want to ensure a well-balanced diet in those with dementia. Most um, so I shouldn't say most, many individuals with Alzheimer's disease also have risk factors for stroke, cardiovascular disease, etc. So we often do recommend heart healthy diet, which is similar to a brain healthy diet. So looking at foods that are, high in healthy fats, high in fiber, whole grains, low processed food, low refined sugars, things like this. But as far as specific dietary recommendations, there's nothing that's been greatly studied. As the disease progresses, as we approach the severe to late stages of dementia, our shift focuses more on, like we talked about, the palliative approaches to care, comfort care, symptom management, feeding for comfort, feeding for pleasure. So we often don't care as much about types of food in the late stages. We care more about quality of life, calories, etc. So if your loved one, their nutritional intake has declined, they now are, largely bedridden, they're not able to eat a meal anymore because of their advanced dementia, but they eat ice cream and they enjoy ice cream, give them ice cream. So really the focus is more on comfort, quality of life, rather than longevity. And so really dietary recommendations change depending on the individual, but I hope that sort of gives you an example of sort of how we might approach diet across the spectrum of dementia care.
We have another question here. It says, what is the best way to share sad or upsetting information in the moderate stage?
Yeah, that's a good question. I think, again, it's going to vary from person to person. Generally speaking, we want to give information in bite-sized pieces. We don't want to overwhelm an individual with dementia, knowing that they may not be able to retain or understand or comprehend information as well. And processing speed may be harder. So involving your loved ones in daily life matters is important, and to involve them in a way that makes sense for the stage of the dementia they're in. So simplifying things, bite-sized pieces, and that really depends on the stage, the individual, if they're able to appreciate that information or not is going to depend on the stage of dementia. But I would say, generally speaking, communicate in ways that are in line with what that individual is able to understand, and keeping things simple, bite-sized pieces, and not to overwhelm with information that might be emotionally distressing.
The next question is, what would your top recommendations be for slowing progression in regards to lifestyle choices?
Oh, that's a good question. So I would say that the interventions that we know prevent dementia are most effective before dementia sets in. So a lot of the changes we recommend, or lifestyle choices that we recommend, are things that we recommend now, like in our young adult years, middle-aged years. So those things would include exercise. I would say that's probably the top thing. So staying physically active. We know that a sedentary lifestyle is a risk factor for developing dementia, amongst a host of other conditions. So I always tell patients that if I could prescribe a medication that had a lot of benefit, it would be an exercise protocol. So exercise is always top of mind. Not smoking and not drinking alcohol, or drinking in moderation. And the Canadian guidelines actually recently updated the alcohol guidelines with significantly lower recommendations. And a lot of that was driven by new information that has shown us that alcohol is a strong risk factor for dementia. And as we age, even small amounts of alcohol can impact our brain, and alcohol is actually toxic to brain cells. So avoiding alcohol as much as possible, or minimizing how much we drink, and minimizing it to, only a few times a year rather than multiple times a week, would be my recommendation. Oh, what did I say? So, and then I guess diet. So diet is another one that I would say is important. And again, there's studies looking at the Mediterranean diet, which looks at, again, whole foods, healthy fats, lots of leafy greens, fruits, vegetables, fiber, low amounts of red meat, plant-based protein, minimal processed foods, diet that's low in refined sugars, things like that. So whole food diet, exercise, and minimizing alcohol and not smoking would be my top three. 4, I guess.
The next question is, have you ever heard that cholesterol medication being linked to Alzheimer's or dementia?
That is a good question. So the answer is no. There's not a link, but I know the studies that you're referring to, those were flawed associations. So there's often, we often worry when results are interpreted in a way that isn't reflective of the study. So in other words, causation is not the same as correlation. And so oftentimes individuals who are elderly are on statin pills for other conditions, whether it's heart disease, stroke, whatever it may be. And majority of individuals with dementia are elderly. So I would say there's a potential correlation between persons on statin therapy who develop dementia, but there's not been an evidence to support a link between statin therapy and the development of dementia, or at least not a strong link. And it's certainly not something that I teach students, residents, and it's certainly not something that I talk to patients about. If anything, I think statin therapy is very important, particularly if you have a history of a stroke or a heart attack, because we know that one of the strongest risk factors for developing dementia is a stroke. So certainly, I hope that answered your question. The simple answer is the studies that talked about that were flawed, and no, there's not strong evidence that statins cause dementia.
Okay. Our attendees they do a lot of research. So there's another one about an article that recommended eating walnuts, which is high in choline, to increase acetylcholine levels in the brain to help with memory. Have you heard of this? I hope
Yeah, no, thank you. So choline levels. So certainly, we know about the benefits of certain nuts. And I believe, if I'm not mistaken, walnuts are high in, I want to say, vitamin E, but don't quote me on that. But certainly, nuts are important for cardiovascular health, heart health, brain health. They are part of the Mediterranean diet and a lot of those diets that we study that are good for longevity and aging. So I can't speak specifically to walnuts on their own, but I could certainly see that, yes, they would be very good for you. So absolutely, you should continue to eat walnuts. It's not going to hurt you. And I think certainly is a benefit.
Okay. Does interest in activities tend to fade?
Yeah, so that's a common thing we see. And part of it is the disease itself, where people lose the ability to take part in activities they used to be able to do. So they don't have the functional cognitive abilities to, for example, play that card game that they typically enjoyed, or whatever game of skill they enjoyed. And oftentimes we can develop a condition called apathy, or a symptom, I should say, called apathy in dementia, which is not the same as depression, but it can often look like depression, where people become more withdrawn. They seem perhaps a bit indifferent. They may go along with social activities, but they will never initiate it. They may be quite quiet at family gatherings. They won't engage in conversation, but they're not depressed per se. They just kind of seem content with kind of going along with things, and sort of need that extra push to kind of take those steps. So apathy can often contribute to a loss of interest in activities. Sometimes depressive symptoms as well can contribute to that. And just dementia in general, as we lose our functional abilities, we slowly move away from doing activities, skills that are no longer easy for us to do as a result of the dementia progressing.
I have another question for you. So, does everyone with the Alzheimer's gene develop dementia, and can a person develop Alzheimer's without the gene?
That's a good question. So the short answer is no, not everyone with the Alzheimer's gene will go on to develop Alzheimer's disease. That's similar to not everyone who smokes will go on to develop cancer. So having a genetic predisposition to Alzheimer's disease is a risk factor, just like smoking, alcohol, strokes, diabetes are all risk factors. And what was the other question there? It was a two-part question.
Oh, the other part of the
Okay.
question
Can a person
was,
develop Alzheimer's without the gene? And yes, actually, most cases of dementia are in individuals just randomly sporadic aging, environmental impacts, other risk factors like diabetes, high blood pressure, other conditions in a lifetime that we know contribute to dementia risk. So, absolutely, dementia is usually what we call sporadic, random. It's usually a combination of some genetic predisposition, aging, health-related conditions that affect the brain in a lifetime. And so certainly genetics are not the only part at play in those who develop dementia and Alzheimer's disease specifically.
okay. We have another question. It says, you mentioned that the moderate stage can last several years and end stage months. Generally, how long would the severe stage be expected to last?
That's a really good question, and I try to avoid putting timelines on it because it is highly variable. Um, some literature would say that, the mild stage can last a couple years, moderate a couple years, severe a couple years, and then end stage usually we're looking at months. So it really, really varies from person to person. But we're still talking years. So short years, it really varies from person to person. 1 to 2 years on average for severe, but again, it sort of varies.
Well, I think that is it for the questions for tonight. I want to thank you again for this great presentation that you put on. And I would also like to thank our sponsors, SGI and SaskTel Telcare. And thank you to the team of Alzheimer's Society who worked hard tonight behind the scenes to make this presentation run smoothly.